been a big year for venetoclax in AML. For many years, trials in older patients with AML had a typical scenario of improving response rate, but not actually improving overall survival. And this is mainly because in older patients, there's a higher proportion of patients with poorer risk disease, patients that are frailer, and they have more comorbidities, and therefore the toxicity of various treatments is more accentuated in the older populations. Over the years, there's been development of new drugs targeting BCL2, with the main player being venetoclax. And through a series of initially single phase 1 and phase 2 studies, it's been demonstrated that venetoclax in combination with low-intensity therapies such as low-dose Ara-C and hypomethylating agents produced quite promising response rates. This led to conditional approval of venetoclax for AML in older patients considered unfit for intensive chemotherapy by the US FDA, and then the relevance of doing 2 parallel phase 3 trials to determine the efficacy of venetoclax in combination with either low-dose Ara-C in a phase 3 randomized trial called VIALE-C, or venetoclax in combination with hypomethylating agents such as Azacitidine in the VIALE-A trial. The results of these studies were recently presented at the European Hematology meeting, and I'll talk about these briefly. So with respect to venetoclax in combination with hypomethylating agents or Azacitidine, there was significant improvement in response rates in patients aged 75 years or older or considered unfit for intensive chemotherapy. So the response rate for venetoclax with Azacitidine was 66% compared to 28% for Azacitidine alone. Similarly, in the VIALE-C trial, there was a substantial improvement in the response rate for patients receiving venetoclax in combination with low-dose Ara-C, with responses increasing from 13% to 48% with the combination therapy. These big increases in response rate translated into significant improvements in overall survival in both studies. And so the success of the VIALE-C and the VIALE-A trials really does underpin the hope that venetoclax will become a very important component of care in the future for older patients with acute myeloid leukemia and those considered unfit for intensive chemotherapy. In my talk, I also walk through some of the subgroup analyses which illustrate that for venetoclax in combination with Azacitidine, there's particularly strong survival benefits for patients with IDH1 and IDH2 mutant disease. Whereas for the VIALE-C trial with venetoclax in combination with low-dose Ara-C, patients with NPM1 mutation also seem to do the best and to have quite impressive long-term outcomes compared to low-dose Ara-C alone. I also talk about some of the recent work which has looked at some of the resistance mechanisms with venetoclax in combination with low-intensity therapies, and 2 molecular subgroups stand out, including patients with FLT3 mutation and those with TP53 mutation. Although patients with both of these entities can have a reasonably high response rate with initial therapy, there is a tendency for relapse to be more frequent, especially in the absence of NPM1 mutation. And so this indicates that we need to do more trials in the future to find more improved therapeutic options for these 2 subgroups of patients. Obviously, for patients with FLT3 mutation, new combinations with FLT3 inhibitors, either venetoclax with a FLT3 inhibitor or the possibility of triplet combinations with the addition of a FLT3 inhibitor, are things which are being looked at in the future. And also for patients with P53 mutation, we perhaps need to look forward to the possibility of newer agents such as anti-CD47 antibodies, such as magrolimab, or APR-246, which is another small molecule thought to have enhanced activity in patients with mutant or deficient P53. Finally, maybe taking advantage of the very high response rates of venetoclax with low-intensity therapies with respect to taking patients in remission, perhaps with a better quality of condition, to allogeneic stem cell transplant as another means of overcoming poorer outcomes in certain subgroups, such as adverse cytogenetic risk or P53 mutant disease. So with that, I'd like to thank you for listening, and I think we all look forward to a very much brighter future for patients with AML in older age groups than has traditionally been the case. Thank you.